Bueno, vamos a dar inicio. Good afternoon, everyone. Welcome to a new webinar of the Arrhythmia Council of the Argentine Society of Cardiology. Today, I have the great honor of presenting a world leader in the electrophysiology field. And although he needs no further introduction, he is professor of medicine at Perelman School of Medicine at the University of Pennsylvania. I am pleased to know Dr. David Callans personally, and I can also say he's a fantastic person. Those who have visited his EP lab in Philadelphia will already know the way he works and everything that is very difficult, he manages to make it seem easier. We also count with an excellent panel for further discussion. Dr. Sergio Dubner, Head of Electrophysiology at Clínica Suizo Argentina and at Sanatorio de los Arcos. He is former director of the Arrhythmia Council. Dr. Gustavo Iralde, electrophysiologist at Cardiovascular Chivilcoy, also member of the council. And Dr. Ivan Tello Santacruz, electrophysiologist at the British Hospital in Buenos Aires, and actually member of the Arrhythmia Council too. I suggest the audience to use the chat for your questions and keep the microphones off. So, David, thank you very much for your presence and collaboration with us, and it will be a great pleasure to listen to you. So you can start your lecture.
Wonderful, Nico. Thank you for that way overly kind introduction. Buenas tardes, friends in Argentina. Thank you for the honor of being able to present to you today. I hope we'll find this interesting. I'm very fascinated with PVC and PVC ablation. And hopefully some of the following slides will show a little bit of the tricks and tips that we've been working on for the last several years. Trials and Tribulations is a little bit of a melodramatic title, but I think you'll see what I mean. Oops. There we go. So we're talking about idiopathic PVCs and also ventricular tachycardia, or we could just say ventricular arrhythmias that are idiopathic. They can come from really anywhere in the heart muscle, but the common locations are from the outflow tracts, from the inflow tracts, paravalvular, from the papillary muscles, from the Purkinje network, rarely from the apical structures. When he was a fellow with us, Rob Schaller, and I was an attending with us, put together this experience. I think this was about 6 or 7 years ago. Over several years, what sort of experience we had with locations for PVCs. And you can see that they're overwhelmingly from the right ventricular and left ventricular outflow tract. Back then, we saw very few papillary muscle PVCs, and that's really changed. So these are the two settings that I'm really going to concentrate on during this talk. And around this time, again, about 6 years ago, we really conceived of these, particularly the outflow tract PVCs, as actually coming from a spot that we could put our catheter on within the outflow tract. And as we'll talk about soon, we can now say that that's not as true as we used to think that it was. This is a cephalad view of the anatomy of the outflow tract. So we can see the valvular structures, mitral and tricuspid valve, and then more anteriorly, the aortic valve and the pulmonic valve. So these are the areas of the outflow tracts that most PVCs come from. There's a lot of other stuff going on here, obviously the coronary arteries and the conduction system below. And it's interesting that the way that this is projected is that the pulmonic valve is anterior to and leftward to the aortic valve. So the most leftward structure in this whole conglomeration of anatomy is the pulmonic valve. And so that kind of has an impact on the electrocardiography of PVCs that come from this region. If you have a PVC that's negative in lead 1, it almost has to be coming from the RV outflow tract. That's the most leftward structure. Looking at it much the same way for the precordial leads, and this is a nice schematic that was put together by Sam Asirvatham, who knows more about anatomy than anybody else that I know. You can look at the precordial leads. Here looked at lead 1 as an assay of how anterior something's coming from. So the anterior outflow tract, the free wall of the outflow tract, is the most anterior structure, and it has no R waves in lead V1. V1 kind of sitting on the chest adjacent here. As you go more posterior, finally to the mitral valve plane, V1 gets larger and larger until it's a right bundle. It's just more muscle mass being activated on the way towards the chest wall where V1 is sitting. So we look at V1 and we also look at the precordial R wave transition. The more anterior something is coming from, the later the R waves turn positive in the precordial leads. The more posterior something's coming from, the earlier it turns positive in the precordial leads. And that can help us start to know where to map, which space of this complicated space to start out with. So a typical RV outflow tract idiopathic non-sustained VT, there's a couple sinus beats mixed in here, often negative in lead 1, so very leftward, farther leftward than the aortic outflow tract is, very positive in the inferior leads, negative in lead V1, V2, V3, starting to transition in V4. So a very anterior structure. This would be typical for something that would be coming right from the so-called septal aspect right under the pulmonic valve. PVCs from the left coronary cusp are a little bit different. They're still strongly positive in the inferior leads. That structure is a little bit more rightward than the pulmonary outflow tract is, so it can have some positive forces in 1. It's negative in V1, but starts to develop an R wave in V2 and transitions at V3, so more posterior than the RV outflow tract. So the mystery of this starts by looking at the difference between the totally normal tissue that we can ablate RV outflow tract PVCs from. We never see abnormal electrograms. We never see separated late potentials or pre-potentials as we do when we're mapping in the coronary cusps. This is one of those PVCs. So we see very often when we're mapping there that there are dissociated potentials. This is from the left cusp that start late in sinus rhythm and then become early in the PVC. So it wasn't that this tissue was so abnormal, it's just that we're mapping where there's not so much normal myocardium. I'll show that in the next picture. Oh, this is first. So in Philadelphia, we love intracardiac echo. And this is a picture looking at the aortic valve with left cusp, right cusp noted. And I used to tell people that echo is really important because you have to map the whole cusp, the whole semilunar cusp of the left, the whole semilunar cusp of the right, to make sure that you capture these signals that are disjointed. As it turns out, that's not at all true. And we'll see in the anatomic slide that comes next, there's no tissue here at all, except the tissue that's beneath the aortic valve that's kind of, so the part of the aortic valve that sits on the interventricular septum. So this part of the left cusp and this part of the right cusp sits over the superior interventricular septum. And that's really the muscle that's making these PVCs, not the elements of the cusp. The elements of the cusp, this is a trichome stain, so that blue is fibrotic tissue in the right cusp, in the left cusp. So there's no muscle in the cusps at all. Any active electrogram that we're recording from this site is actually the septum that's below it. So we can call this the superior interventricular septum. Sometimes this space is called LV summit. We'll see some more anatomic slides of it. I don't think there's any reason to be confused. I think the LV summit is the epicardial aspect of this. And I think we'll refer to this area as the superior LV interventricular septum when we get closer to it. So nothing comes from the cusp itself. Everything's coming from the septum directly below it. So we're still fine. We thought that when we had RV outflow tract VTs, it came from the muscle right under the catheter in the RV outflow tract. We had coronary cusp PVCs, we thought it came from the muscle right under the catheter is a little bit separated by that fibrous tissue, but we could think of it coming from just under, so that when we put the catheter in the cusp, we could reach it with the energy that we deliver with ablation. Here's a case from, I don't know, 4 or 5 years ago that really made us start to think that that wasn't the case at all. Very interesting patient who had idiopathic PVCs. And this was a colleague of mine. He was mapping the RV outflow tract, mapping the endocardium of the LV, mapping the right coronary cusp. And all of those spots were almost the same amount presystolic, and not really presystolic enough to be the site of origin of the PVC. So in idiopathic VT, you can practically always expect that the earliest electrogram, the electrogram that would be right under the site of origin of the PVC, should have a 30 to 35 millisecond presystolic potential. So this is not early enough, and it's not distinct enough. The earliest spot was in the RV outflow tract. And when he ablated there, something really fascinating happened. The PVC frequency reduced a great deal, but the PVC didn't go away. He next ablated in the LV outflow tract endocardium, kind of adjacent across the septum to this spot. And again, the PVCs went away in frequency a little bit further, but were not eliminated. And finally, ablating in this other facing spot from the right coronary cusp, kind of surrounding something that's probably coming from the middle, the PVCs entirely went away. So this went from being a very elegant thing, finding out where the PVC is actually coming from, to becoming kind of an ablation fest. The PVC is coming from the middle, and we have to gang up and surround it and destroy every vantage point that we can think of to do. Not elegant at all, but that's what happens sometimes. And it seems like it's happening more often than not presently. So if you wanted to take a closer look at the anatomy of this LV summit, which is, so this is the cutaway of the superior interventricular septum. The LV summit really refers to this surface, the epicardial surface of this hunk of muscle. So a blow up of that, we can see some natural partners to this hunk of muscle. The other thing that's important is that we kind of look at this LV summit, the LV epicardium in this space, often by looking at the great cardiac vein as it becomes the anterior interventricular vein. So we can put a CS catheter out that far and really understand this spot. The problem with ablation there is this. These are the left coronary arteries. So they're almost always in pretty direct apposition to the AIV. The other important thing from this initial look at this anatomic structure is that this is the left main coronary artery. This is a big gap, and this is the epicardium. So what lives here and on top of the artery as well in living humans is fat. And so if you go epicardial with your catheter approach, all you confront is fat and coronaries. So the AIV can be a spot for this, but the epicardium seldom is because of the fat and the presence of coronaries. So for a long time, we've kind of looked at the AIV recording as the gold standard, the point of reference to beat if you're ablating in this area. I'll suggest another gold standard that we've been working on lately that might even be a little bit more to the point. The AIV faithfully represents what's happening on the epicardium, and often that's a site of origin for PVCs, but look how thick this muscle is. So there are other ways of approaching the entirety of that slab of muscle. The other vantage point include the left coronary cusp to get at this part of it, the LV endocardium, often with a catheter that's placed retrograde aortic and then curled up to rest very securely against this part of the slab of muscle. There's nothing to say that these PVCs can't come from the LV endocardium proper, so you can map this from there, kind of the opposite end of the spectrum as the AIV. And then finally, and very importantly, the RV outflow tract is coming right alongside all of this, and also right alongside the LAD. So that's another thing to be careful for. So different vantage points to get to different aspects of this slab of muscle. One more piece of the anatomy here. This is the first septal coronary artery, which is also accompanied by a septal vein. And that's part of the story that we'll get to in a second. So you can map all the way on the outside of the superior interventricular septum, or if you had some manner of navigating that vein, you could map also from the inside and tell things like, is the PVC coming from closer to the epicardium or closer to the endocardium, and trying to decide which vantage point to use to try to ablate it. So our first take at this then was, we're using the EIV as the point of reference of choice. So we thought for a while that very many of these PVCs were in fact epicardium, and the easiest approach to the epicardium was the AIV. Sometimes we'd have pre-systolic electrograms and good pace maps from that site, but we try to ablate and were unsuccessful, either because of fear over damaging the coronary artery that's adjacent, or because sometimes when the catheter is so wedged in the vein, you can't deliver any power. You're limited by getting immediate temperature rise. So we looked at 17 patients with PVCs that we thought were coming from the AIV GCV junction, but couldn't ablate there. So what we did instead is looked at the closest neighbor. So the closest neighbor to this space is often the left coronary cusp. So this is an activation map that's kind of representative. Much earlier recordings in the AIV, attempted ablation there, and we couldn't ablate there because of the power limit. Much later in the left coronary cusp, but pretty close. And this 15 millimeters was kind of the upper border of what we could reach. So it's not really coming from the AIV, it's coming from somewhere in the middle. And as long as the left coronary cusp is close to that somewhere in the middle, we can successfully ablate some of those PVCs. It's not coming from the left coronary cusp, it's coming from close enough to the left coronary cusp. If this distance between the earliest spot and the AIV and the left coronary cusp was larger than 15 millimeters, we are consistently unsuccessful. Kind of follow this up again with the realization that the left coronary cusp is sometimes the closest neighbor to this, and sometimes the other vantage points that we were talking about on the anatomic slide are closer. In any case, 53 patients with the AIV being the earliest activation, but not being able to ablate their energy ablation being unsuccessful, most because of proximity to coronary vessels. So an anatomic approach from adjacent structures was successful in nearly half of these patients when we could get close enough. And again, very similarly, if we're within, in this example, less than 1 centimeter, less than 10 millimeters, it was very likely to be successful. More than that, not likely to be successful. So ablating a space to get into the middle rather than the specific spot this is coming from. Let me show this case that is more representative of how we're thinking about this now. And I think this is really exciting work. And this is almost exclusively been done by my partner, Fermin Garcia. And it's really been painstaking and elegant work. So I'm very happy to present it to you. So this was a case that I performed, kind of inspired by Fermin. He was a 58-year-old man. He had symptomatic PVCs with a really high burden. He'd been treated with various medicines which were unsuccessful. And at other institutions, he underwent 2 prior ablations, and both were limited to ablation in the RV outflow tract. So we learned from looking at the EKGs of this that the outflow tract is not where this PVC should be coming from. So it's inferiorly directed, that's fine, but it's positive in V1. So it's got to be coming from posterior to the RV outflow tract. So I was kind of thinking when we encountered this is that, well, we'll just map the structures that are posterior to it, like the coronary cusps, and this will be easy. But the joke started out being on me. So this is this clinical PVC in the lab. Sometimes the electrocardiography seems to change between the surface where the leads are put on and where the leads are put on in the lab, but it looks the same. So this is an activation map, and this is a little bit busy, but this is the RV outflow tract, as far left order as we can get, right under the pulmonic valve. And you can see of all the spaces, this actually is the earliest. This is the right cusp. This is the left cusp. So we haven't mapped over there yet, but we mapped here first, and we had a really early distinct spot. And so we looked at that a little closer. I think this is a really important point. So if you measure this as we measured it, first of all, it's measured wrong. You shouldn't measure to the onset of this. It turns out that it's 35 milliseconds, but look how sloppy this looks. It's really far field looking, not a sharp potential that would really be the site of origin of a PVC. So this is not where it's coming from, but it kind of predicts that we will find, if we look somewhere else, something that is that early, but just a lot sharper. Also, a quick way to screen for this is that when we paste from that spot, it doesn't look anything at all like the PVC. So the paste map looks like it's coming from the RV outflow tract. Very negative in lead V1, and then kind of going down from there. It doesn't match the morphology of the PVC at all. So we still had work to do. So we had mapped the cusps, and they were not any better. So this is work, again, that Furman has done all of this, and there's a couple of different ways of going at this. So Furman started his work with a non-insulated coronary wire that he would place into this spot. So you'll have to take my word from it. You can kind of see, let's look at the REO image first. This is a sheath that's in the coronary sinus and the great cardiac vein. Venogram shows that this vessel here is the AIV. This vessel is not the AIV. This is the first septal vein, first septal perforating vein. We saw the artery on that anatomic image. So this is a multipolar catheter. This is called the MAPIT. There's another thing that we have available to us called the EP star, which is 3 French, which is what we usually do. I was actually trying to put this MAPIT catheter into the AIV, which I knew wouldn't be useful, and it happened to go right in the first septal vein, which is where I wanted it to go. So we didn't need the EP star to do that. So we have a multipolar recording that's coming from inside that vein, which is kind of stretching from epicardium to endocardium, right by the first septal perforating artery. Another way of mapping the depth of that space. So when we did that, we see a sharp potential that's, again, predicted by that far field potential in the RV outflow tract, but much sharper. It's about 35 milliseconds early, really. When we pace map from there, it's much closer, not perfect, but much, much closer to the way that the PVC looks. And so you can't ablate from that. It's too small. You can't hook up energy to those electrodes. But we use that vantage point to see how we can get closest to that from adjacent structures. So as it turns out, the closest that I could get, so this is retrograde aortic, curled back up, and we're going right below the right coronary cusp. Not because it's the right coronary cusp, and instead because that was as close as I could get the catheter to that electrode on the MAPIT catheter that was within the septal vein, the closest proximity I could come with. So when we do that, we lost a little bit of the excellent timing that we had at the catheter before. This signal is not as sharp, but it's about in the same spot. Excuse me. And when we put the ablation catheter next to it, we see something that looks pretty sharp and times out with the activation that we expected to find from the intravenous catheter. So this looks like a pretty good spot. When we ablated there, it didn't work, which I was kind of surprised about. But something really funny happened instead. So we were on the ablation, and the catheter jumped up and went above the aortic annulus into the right cusp. And as soon as the catheter went there, the PVC stopped. They came back. We didn't really apply that much energy there, but we were just a little lower than the actual spot was, which happened to be in the cusp. So when we put the catheter in the cusp for real, the electrogram really isn't nearly as good. And when we paced from that site, when we tried to do a pace map, it didn't look good at all. But when we ablated that spot, the PVCs went away and stayed away. So again, the PVC isn't coming from where I had the catheter. The PVC is coming from within that slab of muscle of the superior intraventricular septum. But this is the closest we could get to the inside where the PVC was coming from. And the way that we know that is the recording from the first septal perforator vein. And all that is due to Perelman. So that works very well for these PVCs. It also works very well, although we're not very effective in this application, but for substrate-based VT from intraseptal substrate in non-ischemic cardiomyopathy. We do the same thing for that. We map to try to figure out where the important parts of the circuit are from the inside out. So I wanted to change gears for the last part of this talk. That was all I was going to say for now, and I'd be happy to answer questions in the question and answer and chat period on outflow tract VT. But I'm really excited about that new work. And again, it's nothing that I've done. It's all been Dr. Garcia's work. I'm going to switch gears to papillary muscle VT, which is another thing that has really troubled us and is not an elegant sort of ablation. It's, again, more ablations than we really should have to give if we could understand this better. So this is a slide that was provided by Neil Kay, and he's making the point, actually several points. So this is the anatomy of the posterior papillary muscle and the anterior papillary muscle. They're poorly named. They're not really posterior medial and anterior lateral, and they're right close to each other. And they're very confusing. They typically have at least two heads, and you have to consider all of this area when you're mapping. The other point that Professor Kay is making is that if you have a focus from the anterior papillary muscle, often it seems to exit in different ways, as if it were coming from the middle and making this PVC when it went to the posterior aspect to exit, and this PVC when it goes to the anterior aspect. So these can appear to be multifocal even when they just come from a single spot, just with separate exits. So another thing that makes this very challenging. So this is a good example of this. So this is a young woman that I took care of. She had idiopathic PVCs that were coming from the papillary muscles and two different morphologies. So this one, I guessed, was coming from the anterolateral papillary muscle. It's negative in lead 1, often has this less positive in lead 2, more positive in lead 3 look to it. And then this one that's coming from the posterior papillary muscle, a little bit of positive forces in lead 1 and negative in the inferior leads. But I was wrong, and wrong in a thankful way. This is a little bit hard to make out. So this is intracardiac echo. We have a catheter retrograde aortic. This is the posterior papillary muscle. And the green tip is a cardosound way of trying to visualize the tip so we can see it. And it's kind of in a very socked in spot on the posterior head of the posterior papillary muscle. And when I ablated there, which is very far away from the anterolateral papillary muscle, both PVC morphologies went away. So sometimes this apparent multifocal nature of PVCs from the papillary muscle is only apparent. It's different exit sites from the same spot. So we struggled with these. We still do. I mean, it's no one's favorite case even now. But when we first started realizing that this was becoming more common, we really struggled. And I kind of came up with this list of difficulties that we specifically have with papillary muscle PVCs. So the first one, and I think the most important one, is the difficulties understanding what really turns into being four-dimensional anatomy. So when we're mapping on the, say we're mapping on the left ventricular septum, it kind of feels like it's two-dimensional. It isn't, but it's a flat surface that we can map on. The papillary muscles have a very intricate third dimension. And then the fourth dimension is they move like crazy. They move much more than the rest of the left ventricle. So the fourth dimension is time and movement. So we were trying to understand this, and it's a much harder equation than it is for other places where we're ablating. The way we solve this is imperfect. We like this application of cardosound. It's not so useful here, and I'll show you that example in another slide or so. But we try to look at it with ice real time. We try to reconstruct the anatomy of the papillary muscles with the cardosound. It doesn't work so fantastically well. Or if you're using a mapping system, sometimes it's helpful to make each individual head of the papillary muscle a separate chamber within the mapping system, so that you can understand at least some of that anatomy and map within it. Another big problem with this is catheter stability. So it's very difficult to find a vantage point that the catheter will stay in. I showed you an example that was very stable, but that's pretty unusual. It's even harder for the anterolateral papillary muscle because no matter how you approach it, there's nothing really to buttress the catheter up. It's kind of hanging out in the middle of nowhere as it's trying to reach that anterior papillary muscle. We can't really use pace mapping so effectively for papillary muscle VT because we really think that the many PVCs are coming from insulated Purkinje fibers, which you can't capture. So you can capture the muscle around the Purkinje fibers. You can't capture the fiber itself. So the actual site of origin can't be really faithfully duplicated with pace mapping. And then this idea of multiple exits that we were talking about before. So here's an example. This is kind of an old slide. So we're ablating, the catheter is coming retrograde aortic onto somewhere in the posterior papillary muscle. And we get a sense for, this isn't the best ice picture in the world. We get a sense that, you know, there's a head of the papillary muscle that's like this and a head of the papillary muscle that's like this. So we're on kind of in between the cleft of the two heads. But we get the sense on echo that it's a very intricate structure and it has a lot of different faces. And we try to reconstruct that with cardosound and it looks like a blob. But the advantage of cardosound is you can get the activation points and the ablation points displayed in some sort of vantage point that you can understand. So we kind of go back and forth between the two to try to understand exactly where we're resting on the muscle and what the activation time is like and maybe what pace mapping is like. But this looks a lot more like a blob than this does. Oh, sorry. This is a slide about stability. So this is a case that actually one of my colleagues did, but I'm happy because it doesn't look like very much fun at all. This is a catheter delivered retrograde aortic to the anterolateral papillary muscle. So this is an RF catheter, and you can see that the contact with the anterolateral papillary muscle is horrible. So if you were ablating right now, which this picture was actually taken during ablation, there's no way that any power would be delivered to any part of this structure. So this was something that my colleague thought that he had the right spot, but just couldn't get the catheter to stay in order to deliver any power. So sometimes cryoablation is useful for this. So cryoablation is harder to do the mapping, but look at the excellent cryoadherence when we're ablating there, same spot, but it doesn't move from the spot that he wanted to apply energy to. And this was successful. This obviously was not. So, you know, we felt like we were doing a terrible job at this, and we had to do so many ablations to make up for the stability problems and the lack of accuracy and mapping problems. And so we were kind of, was almost kind of scared when one of my colleagues, Sanjay Dixit, wanted to put our experience together and how we were doing with this. And I thought it was going to be terrible, but it actually wasn't so bad. So he started with 2015 and went to 2018. And he thought that maybe we were doing better because we were relying consistently on ice imaging during that time. We were also starting to use contact force catheters. But there were some people that had in some patients in that cohort that had procedures with contact force and some that did not. And as it turns out, the contact force catheters really didn't matter that much. So we had 113 patients, most of them with PVCs, some of them with non-sustained ventricular tachycardia. There was a mixture of both anterolateral and posteromedial, and even both in some. So we're really surprised to find out that the acute success was 91%. And clinical success, which we defined as at least an 80% reduction in burden of PVCs, occurred in 82% of patients. I would have guessed about 50%, but we actually did a little bit better than that. And we blamed all of that on understanding ICE imaging, and force sensing didn't really help at all. Here's an example, one of the figures from his paper, which is in preparation for Europace. And I think it really shows a lot about this kind of PVC. So this is a PVC that has the electrocardiographic signatures coming from the left posterior papillary muscle. We're mapping with activation mapping. You can see this very sharp signal that's about 33 milliseconds in front of the QRS onset of the PVC. This sharp signal we think represents Purkinje fiber activation. So very many of these PVCs seem to emanate not from the posterior fascicle, but from the distal ramifications of this. So the Purkinje network just is completely surrounding the papillary muscles. So distal Purkinje system, but seems to be the origin of a lot of these PVCs. When we pace map here, it's not a very good match to the PVC. And you can see this kind of overlined in the Cardo system, the PESO sort of application. Pacing in yellow, PVC in green. It's not perfect, but you don't really expect that it would be, because the PVC is coming from the Purkinje network and we're pacing in the muscle around the Purkinje network. Still, there was a very focal activation point, an earliest activation point on the papillary muscle, and ablation here resulted in termination of the PVC. Another problem that we've recently discovered with idiopathic PVCs that come from the Purkinje network and the papillary muscle, they're a very frequent cause of idiopathic triggered ventricular fibrillation. And those cases are even more difficult than the regular Purkinje papillary muscle PVCs. We saw quite a few patients that had PVCs that come from the right papillary muscle, or the kind of the combination of the papillary muscle and the moderator band. And those are difficult because it seems as though when we ablate on the papillary muscle, very often, the right ventricular papillary muscle, very often will cut off one exit site and then end up having to ablate specifically on the moderator band to cut off the opposite exit site in order to prevent triggered ventricular fibrillation. So to try to summarize these two reasonably difficult applications of PVC ablation, even for the most part in idiopathic VT, you know, when we were thinking back to the way this used to feel, it used to be one of the most precise and elegant ablations that we did. We could correlate the anatomy with the electrocardiography and find the exact spot where one ablation would terminate the PVCs. And with the outflow tract PVCs that are coming from the middle of that superior interventricular septum, or with the papillary muscle VT, it's not elegant at all. It's a lot of ablation, trying to ablate from kind of all sides to surround the PVC, because we can't get a catheter exactly on the spot where it's coming from. So the LV summit, or the LV superior septum, and the papillary muscle VTs, they're possible to ablate, and usually we're successful at them, but they're still pretty problematic. It requires a lot of ablation. We have to understand the anatomy better than we have in the past, and I think the septal wire and making those recordings from the first septal vein is very important. But even with all these tools for both these applications, the success rate is a little bit less than we expect. with other applications during PVCs. And there's a little bit higher recurrence rate. So we still have some work to do. I thank you very much for your attention. I'd gladly take some questions. I'm looking forward to that conversation going forward. And as many questions as you would like to ask, I'd be happy to answer. And gracias.
Okay, David, thank you very much for your very complete and interesting lecture. We'll have a lot of questions, so be prepared.
I'm ready.
I want to remind to the audience to write your question in the chat, so we try to translate them to our panel. Sergio, would you like to start with the question and discussion, please?
Yes, of course. Thank you very, very much, Dave. Really was an excellent presentation, and it was also an excellent turnout because there was more than 80 persons, 80 colleagues.
Wow, that's
so
great.
It's very good. So my first question will be a general question. Do you think that radiofrequency ablation is the first-line therapy for idiopathic ventricular arrhythmias, independent of the age of the patient?
That's a really good question. So I do. We recently put out an expert consensus document that I participated in with heart rhythm, and I could convince almost no one else that that was true. Or I guess what the wisdom of that panel said is that if you have PVCs that come from the RV outflow tract, then certainly, most laboratories have the expertise to do that, and ablation as first-line therapy would make sense. As you stray farther away from that in places that people have less experience with, so whether that's the aortic cusp PVCs or the papillary muscle PVCs, or worse still, the intramural PVCs, at least the panel got less and less interested in ablation because the risks of complication go up, and the need for more experience with doing these procedures goes up, and so they kind of lowered the enthusiasm for ablation. Certainly if medicines don't work, and they typically don't work, or at least for the point of view of electrophysiologists, we only see people in whom they don't work. So we kind of get this negative viewpoint towards drugs. But the guidelines certainly state that for more exotic places, it might be worth trying medicines first. I don't think that's so far from true. I usually offer my patients either. And again, that's kind of a biased observation too. By the time they get to an electrophysiologist, they often want an ablation rather than trying medicines, and they've tried beta blockers before they get to us. So I'm enthusiastic for ablation. I think the guidelines say a little bit different, and the truth is probably somewhere in between.
Estás sin micrófono, Nico.
Okay, thanks. Gustavo, do you like to make any question? You have to turn on your microphone, Gustavo.
Okay, I'm here.
Yeah, okay.
Hi, David. I first want to thank you because of your great job, your great talk today, and all the job your group in Penn have done all this year in this field.
Thank you.
I think there is nothing here that your group doesn't investigate it. So it's very great, your job. I want to deviate the talk to risk stratification a little. You have participated in a work of MRI for risk stratification in PVCs with apparently normal workout, and I want your opinion about this. And if I want to ask you if you always do MRI before ablation in all the patients, and how the possible scars you found change your approach, and if you do, I don't know, program stimulation or something else.
That's an excellent question, Gustavo. And I was actually debating about putting a slide or two in about that aspect this morning, even. So it gets scarier the more that you look at it. So we recently had a paper that came out in JACC EP last month. It kind of was the most complete look at, it was a multi-center compilation. And it seemed to say that, I think it was 20% of people that had PVCs and had a normal echo had significant abnormalities by MR imaging. And many of those patients had inducible VT. Many of the patients with scars went on to develop life-threatening VT or ICD shocks. So the problem with that is that it lacks perspective a little bit. So, you know, even in the US, and we spend so much on healthcare, we can't get an MRI on everybody with PVCs. So I think there were subtle biases that led the individual investigators to get MRIs on specific patients that they were worried about. Whereas people that, you know, had run-of-the-mill PVCs didn't get MRI studies beforehand. So what I think that looks like is that one of the signals that was very strong in that experience was people that had different morphologies of PVCs were very likely to have, you know, something wrong with them, even if their echoes were normal. I think that, you know, if you look at symptoms, so people with PVCs usually have palpitations, but not syncope or, you know, not anything that's more worrisome than that. They have a single morphology of PVC that looks like it's coming from a hotspot, like the outflow tract or like the papillary muscles. They're probably fine. In that experience, there were people with impressive symptoms or family history of sudden death or multiple morphologies of PVCs, and particularly right bundle branch block PVCs. And, you know, that doesn't fit the kind of common hotspot places. And so I think people like that, you know, are the people that probably should be imaged if possible. If not possible, then program stimulation, I think, is another way to try to get at that. You know, we don't know what the real yield of program stimulation is in that setting, but at least it's some. And anyone who has symptoms that are, you know, not seeming, they seem like they're more severe than they should have with this problem, or a family history of sudden death, I think we would take very seriously. But we can't screen everybody with MRI. There'd be no capacity and no ability to bear the cost.
And what is the place of voltage map in these cases?
Yeah, so I've kind of looked at that in a couple of different ways. I think it ends up being complementary. So certainly we would say that in the RV, you know, like looking at trying to differentiate normal from, say, sarcoid or ARVC, voltage mapping probably outperforms versus MRI. And that just makes sense because the RV is so thin walled that it's hard to really, you know, with volume averaging, it's really hard to get good MRI pictures. In the LV, it's probably better with MRI than voltage mapping. And I'm thinking specifically of, you know, like we use MRI a lot in people with non-ischemic cardiomyopathy and find that mid-septal scar that we also do venous mapping for. But MRI kind of falls down in those situations too. You know, unlike, you know, if you have an infarct scar, it's normal on the borders and then becomes dramatically abnormal. And so that is very easy to image. when you have the scar that's intraseptal for non-ischemic cardiomyopathy, there's really not any normal. It's just this diffuse abnormal without a sharp drop-off. So a lot of times it's really hard for MRI to pick that up. So we have examples of where voltage mapping failed to do that. And we have examples where MRI failed to do that and voltage map picked it up. But mostly it's with unipolar voltage mapping in that setting. So that can be helpful. That's another way of that we actually actively use for risk stratifying patients. In idiopathic VT, their voltage should be normal. If it was not normal, then something's amiss.
Okay, David, we have some questions from the audience. Dr. Dario Di Toro wants to know about ethanol infusion to treat PVC. If you perform that, what do you think about?
So we don't do a lot of that. I'm fascinated with the work of Miguel Verderabando, who does that. I just butchered his name. I apologize. Both from the arterial circulation and more recently now, particularly from the venous circulation. So that's kind of a natural. It's got a natural affinity for what Furman's doing with mapping of those venous branches. We can ablate from the venous branch. We can instill alcohol from those venous branches. And with the wire there, it's kind of an easy step to advance a sheath to allow us to do that. I'm not sure why we haven't done more of that, but we really haven't. Miguel's work is beautiful. I think it's kind of like, it sounds silly, but it's a little bit privilege based. So, the interventional cardiologists usually do ethanol ablation for HCM through the arteries. And we don't know who to ask permission from to do venous ablation. And we've talked to Miguel about it, and he said, well, why are you asking permission? You should just do it. But we really haven't yet. Part of the problem is that it's not easy because the venous structures have sinusoids. So the alcohol can be instilled in the right spot and then go away. Miguel was talking a little bit about kind of a contraption with a double balloon. So you have a balloon that will occlude the vein proximally and a balloon that will occlude the vein distally so that the alcohol stays within the vein, in the kill zone that you want to take care of the PVC with. So we probably should be doing more of that, but we haven't done a lot of it.
Thanks a lot. Ivan, do you have any question?
Thank you, Dr. Callans. Yes, I have a lot of questions, but I want to know, even in your hands, sometimes, do you have any rule to stop a PVC ablation procedure?
I'm sorry, didn't quite catch that. I'm sorry.
Sorry. Even in your hands, do you have any rule to stop a PVC ablation procedure?
For futility or for safety?
Safety.
So I've been fascinated with how electrophysiologists are kind of put the coronary arteries in considerable hazard. And when we first started doing this, we said, well, you really shouldn't be within a centimeter of the coronary artery. And then people keep going closer and closer and closer and closer. And so that, and some people just say, well, it doesn't matter. The coronaries are so large, they can't be occluded by RF. And that is definitely wrong. So we kind of settled in on this idea that maybe half a centimeter is fine. And I think that that's also a hazard. So I think if you could say, I'm definitely half a centimeter away from the coronary artery, and I promise my catheter won't move, and I keep shooting the coronary with relationship to my catheter, so I understand that anatomy very well. But usually none of those things are true. For the most part, especially with PVCs, you know, people can really be terribly bothered by them, but it's not as bad as having an artificial heart attack. So I think it's really important to have some humility and stop, and I certainly do. You know, if it can't be done, it can't be done. Now there is another take on this from Rod Tung, who has done a lot of these procedures with Da Vinci robot surgery. So thoracotomy to dissect this space, which is very painstaking. They actually do the ablation with an ablation catheter. But after the fat is pulled away and after the coronaries are retracted under direct vision. When I first heard of that, I thought that was absurd. Who would want to have a thoracotomy for PVCs? But Rod's found a lot of people that wanted to have a thoracotomy for PVCs. The results are excellent, but I don't know. I guess you'd have to have a lot of symptoms.
Okay, Dave, we have a lot of questions from the audience.
Great.
Dr. Aguinaga wants to know the burden of PVC to consider ablation in the patient with left ventricular dysfunction.
That's a really good question. And I think it's a really complicated answer. So I've been fascinated by this, and this is mostly work that has come from Frank Bogan in Michigan, you know, really trying to define what the burden is that causes trouble. And we do that in medicine a lot. You know, we say, well, there's got to be a single answer for everybody. Like what we're going through right now is how many hours of duration of atrial fibrillation do you have to have a stroke? And we can't answer that question so far. And part of the reason we can is because, of course, it's going to be different in everybody. If you have somebody that's completely normal, it would take an awful lot of atrial fibrillation to have a stroke. You have somebody who's really sick and has a CHADS VAS score of 6, it wouldn't take as long. So I think it's the same thing with PVCs. So some people can have 40% PVCs and never develop myopathy. They have pre-existing myopathy. It could be due to the PVCs, maybe it is not. So I don't think there's a number. I think if you have someone that has no other reason to have a myopathy and has a lot of PVCs, I think it takes an open mind to see whether it could be this. When we first started confronting this, it was hard to talk people into having ablation for that. So we'd often use medicines to try to prevent the PVCs. And that often didn't work. So we're kind of trying to persuade people to say, you know, if we've already done all the pharmacologic therapy for LV dysfunction and it hasn't worked, and there's any chance it could be PVCs, maybe we should try to ablate the PVCs. Because the rest of the trajectory down LV dysfunction, despite pharmacologic therapy, is pretty poor. So this might be the best way out. And I think the other qualification there, and this is what, you know, electrophysiologists do and not what general practitioners do, is that if you had PVCs that were coming from a spot where idiopathic PVCs often come from, so one of the hot spots like the outflow tracts or the papillary muscles, you'd say, well, that's not part of the LV dysfunction. I mean, the LV dysfunction is not making that happen. These PVCs look like they're idiopathic PVCs. So even if they were only 5 or 10%, you still might have an open mind towards trying to treat them and see what happens. And that has to be an honest discussion with the patient. You can't say that I know what's going to happen, but you can say that it might help. In somebody that has pre-existing cardiomyopathy, so say you've been following someone, they have non-ischemic cardiomyopathy and they have an ejection fraction of 40% for 10 years, and all of a sudden they come in and they have, you know, 20% PVCs and their ejection fraction has dropped to 25%. So that can be another manifestation of that. So you could ablate that patient. It's not going to normalize his function, but it could get back that missing piece that he lost from the PVCs, if that makes sense.
Okay, Dave, we have a linked question here. Dr. Claudio Adid wants to know if you perform routinely ventricular program stimulation in these cases with left ventricular dysfunction and a high burden of PVC.
I think it's probably like the talk about the MRI people. So if I think that this is PVC-induced cardiomyopathy, and there's no worrisome features of it, the PVCs are coming from a spot that looks like it's idiopathic. Maybe even when you have the catheter at that spot, the electrograms are normal and there's not scar there, and there are no funny symptoms, I probably would not. So if they did have those things, I probably would go into that case with an MRI for two reasons. One, to do risk stratification like we were talking about before, but also to kind of have an idea how likely this problem really was to be PVC mediated. So if you have someone with frequent PVCs, but a lot of scarring on MRI, you can get rid of the PVCs, but maybe the ejection fraction won't really improve. And the problem really is the scarring.
Okay. So we have any further question from the panel, because we have a lot of questions from the audience also.
I have one question because Dave, I know that there is a new technique for ablation using an intracoronary wire. Do you use that for mapping or ablation?
I have not. I've seen those reports and they're pretty exciting, but I'm pretty frightened of trying to do that.
Okay, David, we have some technical question here. What settings do you use for radiofrequency ablation inside the coronary sinus? Power and irrigation rate?
Yeah, so I meant to put that in the main lecture. It's a really good question, and I think it's an important point. So we usually use an irrigated catheter, and there's no real recipe for how much power to use. I think more important is the impedance drop. So if you're in the coronary sinus, we start with really low powers because sometimes the catheter tip is completely surrounded with tissue. And in that case, if you start, at high powers, it could cause a steam pop because that tissue is going to heat up despite the irrigation. There's no place for the irrigation to really work. It's a closed loop if the electrode's completely surrounded with tissue. That also, we have a very storied complication. That was a slide that I almost put in too. That can happen with the papillary muscle VT2. So papillary muscles are seemingly indestructible. We have this case where one of my colleagues was ablating a posterior papillary muscle, PVC. I'm not sure you can see my hands well enough, but this is the papillary muscle. Ablating, powerful ablation as much as he could get and not having an effect. Then went to this spot with the catheter. So this spot is in between the cleft of the inferior wall and the posterior papillary muscle, and ablated there and had an explosion. So high-powered irrigated ablation in normal myocardium is like a nuclear armament. So you really have to make sure that, wherever you are is not overpowered. So the way that we do that, to answer the question directly, in the coronary sinus, I might start with 20 watts and see what the impedance drop is. And we look for 10% of the baseline impedance. We're frightened if it's more than that. We're frightened if the drop is very, very rapid and more than that. Same thing with, the papillary muscles. As long as you're on the papillary muscle and know exactly where you are, you're going to be fine. If you're trying to reach the middle from one of those vantage points, we usually start at 30 and ramp up until we have that 10% impedance drop. But that's all pretty safe. If you're on a free wall that's wedged in, that can be really dangerous all of a sudden, and it just takes a second.
Thanks, Gustavo.
Yes. as always, you put the focus on mapping and put the catheter in the right place, but others have talked about ablating harder, bipolar, half normal. What do you think about these other strategies?
It's a really good question. I think that so all of these strategies that you mentioned, bipolar, half normal saline, I'm not convinced that they've been well enough studied, and I'm really surprised at how very many people, including my colleagues, rushed to this out of frustration. The bipolar study was presented at Heart Rhythm Late Breakers in 2019, and it had a weird study design that might have been responsible for some of this, but there was no increase in efficacy with bipolar ablation and a major increase in complications. So I think that just means that we don't understand that yet. And so from my point of view, my personal safety point of view, if I had a complication like that, I had to face that patient and I said, wow, gosh, I got a little frustrated and, I really tried hard and, made a big complication. I don't know how I could face that person. I think the same thing has been true. And I really, Will Sauer has been kind of the champion when he was at University of Colorado in the half normal saline thing. And Will was an ex-fellow from Penn and he's a great friend. But I think that kind of came out of frustration too. It was something that seemed like it was going to work in vitro and then got moved to people too fast before we understood it. The major problems with half normal saline ablation, you probably realize, are steam pops. And in the clinical trials, there were a lot of steam pops, and thankfully no injuries that they discovered, at least. But I think steam pops should be avoided at all costs if you can.
Yeah.
So I think safety first, and in particular when we're talking about PVCs, no one's dying of PVCs, so why should we push the envelope that much?
David, and what about simultaneous unipolar ablation that was also described in recent years? Do you think what is the utility?
Yeah, we had a study of I think it was 6 patients. So mountains of data. It seems safer. We did rescue some people with simultaneous unipolar ablation, but it's hard to make that fine a point of it when there were literally 6 patients in the study. I think we've been using it some still when we get into trouble with not being able to get something, but it's not a lot of experience to talk about.
Okay. Ivan, do you have any further questions? Because we can stay here a lot.
I want to ask you about the intracardiac echographic study. It's expensive to us. And there is a randomized control trial to support it in PVC ablation.
So I have to apologize for just how spoiled we are with this. And we're very fortunate to be able to, at least at this point in time, afford luxuries like that. There has been certainly not a randomized controlled trial. There have been some observational studies that suggest a benefit. But I don't think that even carries the day. I think it's one of those things that, if you did 20 patients, it might help with 1. And we try to justify it because we're not sure which one of the 20 that's going to be. And we justified it because it adds to the comfort that we have during the case. But can you do these procedures without intracardiac echo? Absolutely so. Absolutely so. And I really like it, but you know, it's not like you're doing the wrong thing if you don't have it at all. I think the point about, you know, how I used to think that you needed to map the whole semilunar part of the cusps, that was wrong. You know, that's not, it doesn't come from the whole semilunar part of the cusp. It comes from sitting over the septum. So that's an easy, well, not easy, but it's an anatomy that you can understand different ways. So you don't have to have it with ice. You can understand how your catheters are moving, understand the relationship with the other catheters that you have in the heart. So I think the more that we learn, kind of the less that we need to depend on ice. Still like it, but it's not essential, no.
Okay, David, I think was Melissa calling you. So it's very late. So apologize.
Oh, it's been a delight. I really appreciate this opportunity. Thank you so much.
So we are going to invite you again because we have a lot of questions for you.
Anytime.
So I think we are on time. We want to thank you in the name of the Arrhythmia Council, and we are glad to hear you again. So I want to say thanks to the audience, and okay, see you in the next webinar.
Sounds very good. Thank you very much. Have a good night.
Same to you. Sergio, do you want to say something?
Just to say thank you very much to Dave for his excellent presentation, and also to the audience. Besides that, to all those people who are behind the screen that make this possible.
Okay. Thank you, David, and greet to Melissa.
Okay.
Okay.
Good to see you.
Nice.